Again, I'm Ryan Reel. I did my medical school at Ohio State University, and residency training at University of Illinois in Chicago, and then I did rhinology and endoscopic sinus surgery fellowship training at California Sinus Institute in Palo Alto. And it's my pleasure to talk to you today about vitamin D and the upper respiratory tract. I have no disclosures other than I'm not a vitamin D expert, and we'll see it may have been a tactical error to give a talk as an otolaryngologist on a primary care topic to primary care providers, but we'll see how that goes. I got interested in this a few years ago because there was a real buzz in our literature about vitamin D and otolaryngologic conditions. And it just fascinated me. I always try to take somewhat of a holistic approach to treating the patient, a curiosity and interest in nutritional and lifestyle modifications that can help treat our patients. So I figured I better dive into the literature and learn before I miss the boat on this. So anybody know what this is? Yes, TB Sanitarium, also known as a solarium. So this is what is now National Jewish Hospital in Denver, and this was their consumption sanitarium in the early 1900s. And back then, even they knew that you take these TB patients, you want to put them out in the sunlight and in the fresh air. And I think by the end of the talk, we'll all realize why they were doing that. So the objectives for our talk today are to review vitamin D and its role in human physiology. I want to discuss vitamin D deficiency and some of the associated diseases, review the current literature regarding vitamin D and common upper respiratory tract ailments, and hopefully I can help you identify patients in your practice with upper respiratory tract diseases that are at risk for vitamin D deficiency. So just a quick review of vitamin D metabolism. So we need to make vitamin D through the interaction of our skin and sunlight. So UVB radiation enters our skin from sunlight. There's a vitamin D precursor in our skin called 7-dehydrocholesterol, and that 7-dehydrocholesterol gets activated by the UVB radiation and becomes D3. That D3 is not the active form of vitamin D, but it enters the circulation and then goes to the liver. In the liver, it gets hydroxylated and it becomes 25-hydroxy D3. That is not the active form of vitamin D, but it is the most abundant form of vitamin D in our body. To become the active vitamin D, the conventional wisdom was that it had to go to the kidneys and undergo a second hydroxylation where it became now 1,25-hydroxy vitamin D3. And I learned in medical school that once it was 1,25-hydroxy vitamin D3 after second hydroxylation in the kidneys, it could do its job, which was to increase calcium absorption in our gut and put calcium into our bones. You can also get some dietary vitamin D3. Again, it's not active until it goes through the liver and the kidneys, but there's not a lot of vitamin D that you can get in the diet. Most of it's through sun exposure. Conventional wisdom when I was in medical school was that vitamin D is really a rock star with respect to bone mineralization and calcium homeostasis. And obviously there was an association with osteomalacia and rickets. And vitamin D really came to the forefront after the Industrial Revolution. In Northern Europe and the United States, 80% of kids were vitamin D deficient and having rickets. And when the rickets epidemic first happened, we didn't really know what was going on, but these kids would get better with cod liver oil and when they were outside. But the reason was these kids now, instead of growing up out in the country and playing out in the sunshine, they were playing in dark alleys during the day. So governments caught on to this and they recommended vitamin D fortification in our foods. So now most cereals, milk, and orange juices are fortified with vitamin D. You're going to get about 100 IUs per serving of orange juice and milk. And that was enough to pretty much eradicate rickets. Rickets still exists, but it's much less now. Now we're going to talk mostly about extraskeletal manifestations of vitamin D deficiency. And the reason we still have vitamin D deficiency despite vitamin D fortification of food is because it took just a low level of vitamin D to stop the bone mineralization problems. But the behavior that caused rickets really has not changed. So as humans, we evolved outside, and we evolved to make vitamin D through our interaction with the sun. But now the computer age and digital addiction has moved us even further away from our ancestral behaviors. So we're making even less vitamin D now. So vitamin D deficiency persists, but just without rickets. Lots and lots of extraskeletal diseases are associated with vitamin D. These are all associations well documented in the literature. I'm sure you're well aware that there's an abundant volume of literature about vitamin D and many of these things. These patients are often misdiagnosed as having fibromyalgia because they have muscle pain, weakness, and fatigue. A litany of cancers, including melanoma, are associated with vitamin D deficiency, autoimmune diseases, neurologic and psychiatric disease, cardiovascular disease. If you're a male and you're vitamin D deficient, you're 50% more likely to have a myocardial infarction. Infectious diseases, dermatologic, and then we're going to spend a lot of time talking about respiratory disease, obviously. So why is vitamin D deficiency associated with so many diseases? Well, it turns out that it's not just bone, but every cell in your body has a vitamin D receptor. And the vitamin D receptor is actually a nuclear transcription factor, which can express up to 2,000 genes that we know about so far. So this really is epigenetics at work. Take in a substance, it turns on nuclear transcription factor, starts producing genes. So external substance taken in changes your genetic expression. So that's epigenetics. Fascinating. This is what really got me hooked on the vitamin D story when I read this paper. It turns out that respiratory epithelial cells, specifically sinus mucosal cells, not only contain a vitamin D receptor, but they also contain 25-hydroxy-D1 alpha hydroxylase, which is the enzyme that we thought was only in the kidney that activates vitamin D. So it turns out that the respiratory mucosa can actually activate vitamin D. Vitamin D receptors have also been confirmed in macrophages, antigen-presenting cells, lymphocytes. Vitamin D inhibits pro-inflammatory cytokines. It prevents eosinophil recruitment, and it promotes cathelicidin production. This is all well documented in the literature. What is cathelicidin? Cathelicidin is the only antimicrobial protein that humans make. It kills viruses, fungi, and bacteria, and its production is upregulated by vitamin D. What is vitamin D deficiency? Well, if you look at Sonora Quest or LabCorp, they will tell you that less than 20 nanograms per ml is deficient. If you talk to an endocrinologist, they will tell you that 40 to 60 nanograms per ml is the preferred level, actually. And this comes from multiple studies, but really the endocrinologists have done good studies where they looked at the appropriate level of serum vitamin D that you need to keep your parathyroid hormone level in the right range. So when you are vitamin D deficient, actually your serum calcium drops, it drives up your parathyroid hormone level. When you supplement those patients with vitamin D, their parathyroid hormone level drops back down. So they found that 40 to 60 was the right number to get that parathyroid hormone level normalized. Additionally, if you look at hunter-gatherer societies still in parts of the world where they live ancestrally, they live outside, they farm outside, they are outside all the time exposed to sun, they maintain vitamin D levels at 40 to 60 nanograms per ml without taking supplemental vitamin D. So that's probably where we're supposed to be. Vitamin D deficiency is a global problem. This is percentage of the population less than 20. This is us, United States, 36% of our population. Northern Europe at an astounding 92%. Mongolia, 98%. The Middle East, 90%. You can see our northern neighbors up here, Canada, 61%, and Australia, 31%. You can get vitamin D deficiency in sunny locales. Miami, Florida, 39% of random sampling were vitamin D deficient. Southern Arizona, Tucson and Phoenix residents, 25% of the population. Now, mean age of 65, but 25% of that population is vitamin D deficient. This should not surprise you. Dermatologists have about as much affection for the sun as vampires. 83% of Australian dermatologists, 47 Australian dermatologists were sampled. 83% of them were vitamin D deficient. 15% of them had levels that are generally associated with rickets. How do you diagnose vitamin D deficiency? You probably all know this, but as an otolaryngologist, I need to make sure I'm ordering the right test. You want to order the vitamin D 25 hydroxy total. Remember, that's not the active, so it's 125 that's active, but this is the best we can get. The 125 hydroxy vitamin D assay might be coming soon, but right now this is the best representation and extrapolation of what your active vitamin D level is, ordering that most abundant 25 hydroxy total. And the names can kind of get confusing, how you call it and where you put the OH and D3 and all that, but it's all the same. All right, vitamin D and ENT disease. That's why we're here today. So clear associations in the literature. Vitamin D deficiency is associated with periodontal disease, allergic rhinitis, chronic rhinosinusitis with nasal polyps, otitis media, acute respiratory infections, adenotonsillar hypertrophy, obstructive sleep apnea syndrome, and head and neck cancer recurrence. So I'm going to march us through some of the papers that I've looked at over the last few years to just educate myself. Study of 156 newborns they showed an association when they were less than 20 nanograms per ml, newborns, 6 times more likely to get RSV in the first year. Nearly 19,000 patients studied, association was found. Vitamin D deficiency, more likely to have had a recent upper respiratory tract infection, and that effect was exacerbated if they had a diagnosis of asthma. There has long been, amongst vitamin D experts, a theory that the seasonality of influenza, meaning the likelihood of influenza to spread epidemics in the winter, is related to vitamin D. And what happens is all populations in the northern hemisphere will get a spike in their serum vitamin D in the summer months. So these are months on the x-axis. So this is June, July, August. So this is when people are outside and the zenith of the sun is appropriate to make the most vitamin D based on the position of the sun in the solar system relative to the Earth. So if you're in the northern hemisphere, you're going to get a spike peak of your vitamin D level in the summer months. And we see an associated nadir in influenza deaths in the summer. And then when the vitamin D drops off in the winter, the influenza deaths rise. Three other papers here showing vitamin D deficiency associated with upper and lower respiratory tract infection. Again, just association. What about chronic otitis media and vitamin D? Case control study, 357 children. They found that the children with higher serum vitamin D levels had less risk of chronic otitis media with effusion. What about allergic rhinitis? I came across 3 good papers that showed vitamin D deficiency was associated with allergic rhinitis, and one of those papers showed that the severity of allergic rhinitis symptoms was worse in vitamin D deficient patients. I did come across this abstract that claimed to be a systemic review of vitamin D deficiency and said that it's not associated with allergic rhinitis incidence or prevalence. That was presented at the American Academy of Allergy Immunology in 2016, but it has never been published. So I don't know if it's still coming through the pipeline or maybe the the data was suspect, but that hasn't been published yet. This was another paper that really caught my interest, that I read with enthusiasm. This was back in 2016. The relationship between serum vitamin D and chronic rhinosinusitis, a systematic review. It's 7 papers that looked at vitamin D deficiency and chronic sinusitis. That paper and a couple of other papers that came out that year, basically the take home is that amongst chronic sinusitis patients, low vitamin D levels were associated with nasal polyps. There are 5 studies showing that. Allergic fungal sinusitis. So if you had a diagnosis of chronic sinusitis and your vitamin D was very low, you were more likely to have a diagnosis of allergic fungal sinusitis. You were also more likely to have increased symptom severity. Amongst patients with chronic sinusitis who had low vitamin D, they had more severe CT findings than patients with normal vitamin D. African Americans had much lower vitamin D levels than non-African Americans with chronic sinusitis. And vitamin D was inversely correlated with polyp size. So what they found was that the patients, the lower their vitamin D was, the bigger their nasal polyp scores were on endoscopy. Low serum vitamin D is also associated with obstructive sleep apnea syndrome, adenotonsillar hypertrophy, airway muscle myopathy. CPAP therapy independently increased vitamin D levels. I didn't have time to look into the physiology behind that, but I thought it was very interesting to mention. Interestingly, vitamin D level is inversely associated with tonsil and adenoid size. So the bigger your tonsils and adenoids are, the lower your vitamin D level is, the more likely you are to have adenotonsillar hypertrophy. Okay, so those are all just papers showing association. Big deal. What about causation? So we'll kind of march through that. There have been some interesting in vitro studies that I wanted to bring up that I came across. Benchtop research, topical vitamin D inhibits nasal polyp fibroblast proliferation in a dose-dependent fashion. And inhibition of nasal polyp fibroblasts by budesonide was enhanced. Budesonide is Rhinocort. So inhibition of nasal polyp fibroblasts by Rhinocort was enhanced with the addition of vitamin D. So this is all lab. This is in vitro. This is an interesting paper that was in the otolaryngology literature. They found that sinonasal epithelial cells produce 25-hydroxy-D1-alpha hydroxylase. That's what I mentioned earlier in the talk. So the sinonasal epithelial cells can actually activate vitamin D. When they dripped liquid vitamin D onto the sinonasal epithelial cells, those sinonasal epithelial cells produced the 125-hydroxy-D. So they actually took vitamin D in its unactive form, put it on the cells, and then they were able to measure a level of active vitamin D. Interestingly, that D3 topically on the sinonasal epithelial cells resulted in expression of cathelicidin. Remember, cathelicidin is the antimicrobial protein that kills bacteria, fungi, and viruses. This was a really cool paper done in mice from the allergy literature. And what they did is they took mice and they made them allergic mice. And that's what that's what that OVA means. These are allergic mice. They're ovalbumin sensitized mice. You can ignore these lines here. These are control mice, the PBS. But concentrate on these OVA bars. Those are allergic mice. On the y-axis is bronchoalveolar lavage fluid levels of IL-5. Remember, Dr. Rubin was talking about IL-5, inflammatory cytokine in allergic disease. So they did bronchoalveolar lavage on these poor mice and measured the IL-5 in their bronchi. And these bars are associated, that DEF, that means that's a vitamin D deficient mouse. That's a mouse that didn't get any vitamin D. This sufficient is a vitamin D sufficient mouse that they gave 2,000 IUs per kilogram. Those mice ended up having an average serum concentration of 31 nanograms per ml. This is an allergic mouse that's been supplemented, or these are allergic mice that have been supplemented with vitamin D. Their serum levels on average were 67 nanograms per ml. And look what happens with IL-5 levels. If they're deficient, these mice were 5 nanograms per ml, by the way. If they're deficient, lots of IL-5. As you supplement, you basically make this mouse close to non-allergic. Same study, same mice. Up here are the controls. These are non-allergic mice when they're deficient, sufficient, and supplemented with vitamin D. Same serum vitamin D levels I mentioned in the previous slide. These are the allergic mice. Look at the allergic mouse that's vitamin D deficient. This is a bronchus. Look at all the airway remodeling. The airway is nearly completely obstructed. This is a vitamin D sufficient mouse. Remember, 31 nanograms per ml of vitamin D in an allergic mouse. The airway is more open. And this is a vitamin D supplemented mouse, bumping up the vitamin D level to 67 nanograms per ml. And you get an airway that starts to look almost normal, like a non-allergic mouse. Okay, so what? Let's move on to vitamin D3 therapy intervention in humans. And when I was reading all these association studies, I was thinking, oh, that's really great. But we go to the ENT meetings, and I would always ask questions about vitamin D, and they would, sit down, son. There are no studies in the otolaryngology literature that show that, sinusitis is made better by vitamin D. But I think we're getting close. And here's what I learned. So we'll talk about vitamin D in upper respiratory tract infections. So study done in 2004, 94 pediatric inner-city patients. Again, remember, inner-city patients, high risk for vitamin D deficiency. They found that cod liver oil that had 600 IUs per day decreased the frequency of winter upper respiratory tract infections. This is actually a landmark paper out of Japan that gets referenced a lot in the vitamin D literature. They did a really nice job with this study, Urashima et al. They did a randomized trial of vitamin D supplementation to prevent seasonal influenza A in school children in Japan. They took 334 kids. They randomized them to no vitamin D or getting 1,200 IU of vitamin D daily. And they found that those kids who had those kids in the vitamin D group had fewer respiratory tract infections and less influenza than the other group. Study 2011, Journal of Allergy and Clinical Immunology, vitamin D supplementation in asthmatic children on inhaled budesonide reduced the risk of asthma exacerbations. 2012, published in Pediatrics, randomized controlled trial of 744 children in Mongolia. Remember I showed the Mongolia, they had really high levels of vitamin D deficiency. They took this group of 744 kids and they randomized them. Half of them got cow's milk that was fortified with 300 IUs of vitamin D, and the other half got cow's milk without vitamin D. They found that the experimental group, their vitamin D went from 7 to 19. Not bad, and the fortified group had a decreased risk of acute respiratory tract infection relative to the control group that did not get vitamin D. Study out of JAMA in 2012, and I'm not just up here to sell vitamin D. There are some studies that didn't show any benefit. So this is 322 healthy adult hospital workers in New Zealand, and the effect of vitamin D3 supplementation on their URI frequency. Now, they did something weird here. They gave them 100,000 IUs of D3 once a month for 18 months. So they really blasted them once a month. Now, they did get their serum level up from 29 nanograms per ml to 50, but between the control group and the group they blasted, they didn't find any difference in frequency of infection or number of infections. British Medical Journal, 2012. This is a study in 140 patients with immunodeficiency. They gave them 4,000 IUs daily versus placebo. 12 months, they bumped up their vitamin D from 20 to 50, and they found a lower infection score among the vitamin D group. This is a study in patients who it was actually a study on colorectal carcinoma patients. They were looking at vitamin D, and then just as an aside, the authors decided, hey, let's look and see if vitamin D prevents colds in these patients. So they asked them to self-report the number of upper respiratory tract infections they had while they were on the vitamin D. And the authors found no difference. But one of the problems that was pointed out in this study is that they were letting the control group, the group that shouldn't be getting vitamin D, they were allowed to take home vitamins. And they did admit that some of those patients were taking up to 1,000 IU of D3. So this may not have really been a control group. What about otitis media? Randomized controlled trial, 116 kids with recurrent acute otitis media. They compared placebo versus 1,000 IU vitamin D daily. They found fewer episodes of acute otitis media in the vitamin D group. This is a study looking at 2 groups that were supplemented. They gave one group normal dose of vitamin D. These kids got 400 IUs daily. They gave the other group 2,000 IUs daily, which was considered high dose for a kid. And they found no difference in the number of URIs between the 2 groups. All right, this is actually probably the most important study that's come out on vitamin D and upper respiratory tract infections. It's a systematic review and meta-analysis, 25 randomized double-blinded placebo-controlled trials, 11,000 patients. And what they found was that vitamin D supplementation offers a statistically significant reduction in number of patients having at least one respiratory infection. Vitamin D resulted in statistically significant reduction in acute respiratory infection rate. Vitamin D offered a strong protective effect for those with baseline vitamin D levels serum less than 10 nanograms per ml, but they found that there was no effect if the people started above 10. They found the papers that the folks got daily or weekly dosing, those patients got benefit and were protected against upper respiratory tract infections. Bolus dosing, like once monthly or even less frequent, had no effect on infection rate. So what did we learn? Supplementing patients with a 25 hydroxy D level less than 10 is probably helpful. Daily or weekly dosing tended to work. When you supplement people with reasonable vitamin D levels, it didn't seem to help. So if they're already had a good level, it didn't seem to help them. And supplementing with vitamin D once monthly didn't work. So should it be recommended? Probably, yes. When less than 10, daily or weekly dosing is best, and avoid monthly bolus dosing. So who are our patients at risk of vitamin D deficiency? African Americans, they have more melanin in the skin, so they absorb less UVB radiation and they don't make as much vitamin D per unit of time they're out in the sun. Obesity, vitamin D is a fat-soluble vitamin. These folks need 2 to 5 times more oral or sun-induced vitamin D. Elderly, something about the skin of the elderly, they don't have the capacity to convert the 7-dehydrocholesterol to vitamin D as much as younger skin. Fat malabsorption, for obvious reasons, they're not going to absorb that vitamin D supplement you're giving them because it's a fat-soluble vitamin. Folks who have infrequent sun exposure, like all of us who are working all day. Northern latitude, recurrent respiratory tract infections, and I would argue that any patient with chronic sinusitis and nasal polyps is at risk for vitamin D deficiency. So how do you prevent it? Sensible sun exposure. There's this concept of something called the minimal erythemal dose that was put forth by the endocrinology community. Minimal erythemal dose is what you get if you go out in the summer, midday, in a bathing suit, and you let your skin get just pink, and then you get out of the sun. No sunblock or anything. If you do that, you make the equivalent of 20,000 IUs in that time. So therefore, it's been deduced and looked at by the endocrinology community. If you go out midsummer and you expose just your arms and legs until it's just pink, and in Phoenix that can be less than 15 minutes, you could probably make about 3,000 IUs, just arms and legs, minimal erythemal dose. Oral supplements, all adults should get 2,000 IU daily. It's based on the National Endocrinology Guidelines. Children, 1,000 IU daily. And it's, if in an adult, you can go up to 10,000 IUs per day. I'm not advocating any of this, by the way, but I'm telling you what the literature tells us, that they've done studies up to 5 months, 10,000 IUs a day. Patients did not get toxic. In your syllabus, you have vitamin D levels in foods. As you can see, you're not going to get a lot of vitamin D in food. Not a lot. Again, not a lot in food, okay? Glass of milk, 100 IUs. You can drink 20 glasses of milk to get your 2,000. I put this slide in there because if you live above the 37th parallel in the winter, you don't make any vitamin D. So you have to, our relatives, you have to tell them to supplement. So what do you do when your patients are really low? Well, if they're really low, you can't just start them on a supplement and think that they're going to come up. You have to fill the tank, so to speak. That's what Dr. Michael Hollick advocates. He's an endocrinologist, MD, PhD out of University of Boston, who pioneered vitamin D supplementation research. You give them 50,000 IUs of D3, not D2. You give them 50,000 IUs of D3 once per week for 8 weeks. Then after 8 weeks, keep them on 3,000 IUs per day and recheck. In my practice, I recheck them about 3 months. D3 versus D2, this has been looked at in the literature. D3 is better. It's better to replace with D3. Toxicity is extremely rare. The case reports of toxicity, it's usually because of a dosing or production error. Like literally the vitamin coming out of the factory had like the wrong dose on it. So it's very, very rare that patients would get toxic. All right, summary. Sorry, I went over. Vitamin D is active throughout our respiratory tract. Vitamin D deficiency is associated with recurrent upper respiratory tract infection, chronic sinusitis with polyps, otitis media, head and neck cancer recurrence, adenotonsillar hypertrophy, and OSA. Vitamin D replacement decreases frequency of upper respiratory tract infection. That's been clearly shown in meta-analysis. Sensible sun exposure and daily supplements can prevent deficiency. Consider daily or weekly replacement in patients who have a serum level less than 10 nanograms per ml and avoid monthly boluses. Thank you.